How's everyone today? Good, good. Thanks for being here. I recognize most of you, but my name is Holly Reiner, and I'm fortunate to serve here as our Vice President of Strategic Development and Marketing. This is one of my favorite events every month, and so I'm glad that you're here with us. Thanks to our presenters for being here as well. We'll get started with a reflection. This is called March 4th. March holds one of my favorite days of the year, March 4th. It's the only day of the year that truly tells us what to do in life, March 4th. But this March, I want us to look at marching forth in a different way. I think one of the ways for us to continue to move forward in life is to make sure we take time to hang back, hang out, not get hung up on always pushing, pushing, pushing. I believe we must have our goals out in front of us, but allow ourselves some leeway in how we get there. Ralph Waldo Emerson said, "Life's a journey, not a destination." So it's imperative we enjoy the journey, and we're present for the journey, and we still get enough to remember the journey. This month, focus on ways to be still, be quiet, to be reflective and present. So when we march forth, we're settled, we're calm, and we're centered. So the moving forward is as enjoyable as when we get there. And you know, March is the only month that has a rest built into it, spring break. Therefore, this month that commands us to move forward is also telling us to slow down and take a break. We can do that by creating space in our days and days in our month to be still and unscheduled, so when we do march forth, it's from the very best place possible. Now let's get moving so we can be still. Thank you, Colleen, for that one. We have a number of things in front of you on the tables today. The green door prize slip, so fill that out if you're interested in winning a $20 gift certificate to the Agnesian Health Shoppe. The yellow comment card, so please fill those out. We do take your comments seriously and incorporate them where we can. A number of pieces here, the Health Shoppe contact information. Deb, I don't know if you'll be using these as tools, but there's also another $5 coupon off of any general purchase of $20 or more for the Health Shoppe. An updated Know and Go programming schedule. We've been updating this every month as we have confirmed topics and presenters. And finally, we have an event next week that has quite the headline, Lose Those Stubborn Inches. Where's Heather? So this is a plastic, what is the word?
It's a cosmetic, it's like fat reduction technology.
Dr. Schaefer, this is a new technology that he has to offer, and this will be a time that we can check that out. And then the final sheet, I'll let Deb explain that one, the bathroom assessment. I'm not qualified to go there. All right, so without any further ado, Deb, thanks for setting all this up too. This is, I know it took a lot to bring all that here, and I'm sure you had help, but
I had a lot of help.
All right, with us this morning we have Dr. Bertram and Dr. Parikh, and they joined us both at the same time in August of 2016, and they both see patients all over our system, specifically at the Health Plaza A here in Fond du Lac and in Ripon and Waupun on a rotating basis. Dr. Bertram earned his podiatric medicine degree from Temple University, the School of Podiatric Medicine in Philadelphia, and completed his residency at the Detroit Medical Center. And Dr. Bertram is coming back to Fond du Lac native, which is great. We're excited to have him back and practicing in his hometown. And Dr. Parikh is actually his wife, so they're married, if you didn't know that. She also earned her podiatric medicine degree from Temple University School of Podiatric Medicine in Philadelphia and completed her residency at the Roger Williams Medical Center. They are joined today by our very own Deb Winterhack. Deb is a business development associate for our enterprises, so Health Shoppe and Agnesian Pharmacies. Deb comes to Agnesian HealthCare. She's been here just under a year actually, but has more than 20 years of experience in both long-term care and hospice and operations and in marketing. So please join me in welcoming our presenters.
All right, good morning. Are we okay?
Yep.
Here? All right, thank you, Holly. Good morning, everyone. My name is Robert Bertram. I'm one of the podiatrists, as Holly said. Really excited to be here. I wanted to thank a few people, Katie, for kind of helping put everything together, or whoever else helps put this together. We're really excited to be here. We've done a few of these talks now here, Waupun, Ripon. As Holly said, we go to all three campuses, really. So I'm excited to really speak to anyone who hasn't heard us yet and offer any insight into what podiatry is. So we'll get started. As Holly said, I'm actually from here. I'm born and raised here. I went away for school and training for 10, 11 years really, and kind of came full circle back to Fond du Lac. So For me personally, I'm really excited to be back here, giving back to the community that really, gave me so much and allowed me to get to where I am today. Along that journey, I picked up a wife, kind of spoiled how we gave that away, but for those of you who don't know, we did get married actually a few weeks before we started here. Honeymoon kind of moved in, and before we knew it, we were right in the middle of everything. So I think I can speak for both of us. We're really excited to be here. Things have been going great so far. Everyone's been awesome to work with, so thank you again to everyone who's made that possible. So what are we going to talk about today? This is really, we have about 20-25 minutes between the both of us to kind of cover what is podiatry. It's a little tough to do. I'm going to kind of glance over a few things, but I want to show you and talk about some of the common things that we see really on an everyday basis, either from a clinical standpoint or from a surgical standpoint. Dr. Parikh is going to talk about diabetes. Obviously, that's a big issue within our community, and what issues come about within the foot and the ankle when it comes to our diabetic patients. And then hopefully kind of segue into how we work with the Health Shoppe, and then into to Deb's presentation. So here we go. What is podiatry? Surprisingly, a lot of people don't know what podiatry is. I've come to realize, but it really is anything as far as the diagnosis and treatment of the foot, ankle, or lower extremities. Now that means that means anything skin, bone, nerves, blood vessels, kind of anything and everything in between foot and ankle related. As far as the anatomy goes of the lower extremity, the foot and ankle, there's a lot of bones, 26 bones in the foot, I guess 28 if you consider the leg, the tibia, and the fibula. A lot of joints, a lot of ligaments, and a lot of tendons. So any one of those things can have an issue that comes up that gives our patients pain or discomfort. So it's a lot we have to deal with. Obviously, meaning a lot that can go wrong. So again, I'm going to just kind of glance over some of these things. It's a very brief overview of what podiatry is. There's a lot more, obviously. I could be here all day talking about it, but some of the common things for the practitioners here, the clinicians, if you recognize any of these things in your patients, obviously we're always around to help out. And then as far as, any potential patients in the room, maybe you've had one of these things before. So plantar fasciitis. Anyone heard of plantar fasciitis? I think it's pretty common. It's that heel pain that everyone talks about, that sharp shooting pain in the bottom of the heel. It's really kind of a repetitive stress throughout the foot that results in this poor biomechanics, poor support for your foot. That over time, it is asymptomatic. You don't really notice anything, and then all of a sudden one day it pops up and it's sharp shooting pain in the bottom of your heel. Excuse me. Again, typically due to repetitive or excessive stresses on the foot. Most commonly, it is kind of right on the bottom of the heel. Sometimes it can be on the bottom of the foot as you get closer to the toes. It's something that's very common. I'll probably see 6 or 8 patients later today with plantar fasciitis. So it is self-limiting, but obviously there are things that we need to do or we can offer you to help you relieve some of the pain that you're having. From a conservative standpoint, a lot of it has to do with stretching exercises to kind of lengthen or stretch out your tissues, shoes, orthotics, or arch supports, anti-inflammatories, or just kind of staying off of it. Very rarely will we get to a point where someone isn't progressing with conservative treatment, and that those few patients do go on to surgery, but again, very rare. Achilles tendonitis, this is, I guess, somewhat related. It's, some people will refer to this as heel pain as well. It's pain in the posterior aspect of your heel or within your Achilles in the back of your foot. Again, it's just an inflammation of the tissue, specifically the tendon, in this case, as it inserts into your heel bone. Again, a lot of the treatment is similar as far as from a conservative standpoint, staying off of it, or good supportive shoes, orthotics, anti-inflammatories, But again, once in a while, we do have patients that don't respond to these treatments and end up having to go on to surgery. Bunions, this is, again, maybe right up there with plantar fasciitis, very common. People often think of a bunion as just that bump on the inside of your foot. It is a bump, but it is a lot more than that as well. It's really a biomechanical thing, a progressive thing over time. Kind of a muscle imbalance or joint imbalance that leads to this progressive deformity over time. It's when your big toe kind of starts shifting towards your second toe or towards your other toes, and then you get this big bump on the inside of your foot. Some people are totally asymptomatic. They have it. They don't even realize they didn't necessarily have it because it doesn't cause them pain. Other people, this is actually pretty painful. Again, conservative treatments are always there. We like to start conservatively, but most of the time, like I said, this is a progressive deformity that over time it really just isn't going to get any better. If anything, it's going to get worse. And that's when we get into surgical treatment, which is, really probably 100 different ways to treat a bunion from a surgical standpoint, but really it entails kind of making some cuts in the bone, shifting everything into a better alignment and holding it in place with screws or plates or a combination of those. So again, this isn't something that is always symptomatic and painful, but if it is causing you issues, maybe you can tell your patients that it probably more than likely could progress or will progress, and it's definitely something worth getting checked out. Hammer toes are also a pretty common issue. It's just that contracture of your smaller toes, which again, sometimes or most of the time tend to be asymptomatic, really don't cause any pain. However, they are also progressive. They get to a point too where conservative treatment really isn't going to do much of anything. Conservative treatment is really strappings or paddings to kind of reduce the deformity or protect or pad the prominence. As you can see, the hammer toe, usually when it contracts up, people will have issues wearing certain shoes and it rubs on the top of their shoes. Again, doesn't really mean much or doesn't really cause many issues initially. Over time, as it progresses, you can really actually get some pretty serious complications with skin breakdown, ulcerations, wounds from rubbing on your shoe, which can become infected, and obviously you're looking at a lot bigger issue. So anything you can do to recognize these things earlier on, again, not just hammer toes, bunions, can help things in the long run. Flat feet is a very general term. I'm sure, if I had all you take off your shoes in this room, I wouldn't want to do that. But if I did, the majority of people probably would have what we call a flat foot or a collapsed foot. It's a rather common thing again. Over time, as we get more miles on our body, the older we get, the longer we stay active as a population, the more the stress and the strain is put on our tendons and our ligaments and the joints within our foot and ankle that over time lead to this progressive collapse of the arch. So this is definitely, of anything I talk about today, if this is something that you can catch earlier on, the better off you're going to be either as a patient or as a clinician, referring your patients to get some sort of management, either conservatively or surgically, to prevent things from getting worse in the future. What it is, again, is a collapse of your arch. You really have a few or one or two major tendons that kind of support that arch. If those tendons get worn out or overworked over time, they lose their function, and that's what leads to the collapse in the foot. Again, conservative treatment can be anything from shoes or good supportive shoes, not flip-flops, not barefoot, not anything like that. Shoes with good arch supports or orthotics. Anti-inflammatories are always an option. Physical therapy to strengthen or stretch out some certain soft tissues can all help limit the progression of this deformity. Like I said, the earlier we catch it, the better. The longer it goes on untreated, you end up with a progressive, more severe deformity. that's when we talk about surgical treatment, and that's a bigger surgery. It kind of involves a few different procedures, all with the goal, obviously, of recreating this arch. So definitely something to be aware of. And then arthritis. Arthritis is obviously a very general term. Everyone here has some degree of arthritis in some of their joints. In the foot and the ankle, it's actually very common. Obviously, you can understand that. You're putting all your weight through your foot and ankle every day, every step you take. Just as you get arthritis in your knees or your hips, it's that bone-on-bone contact, that loss of cartilage that leads to the destruction of the joint over time. So most commonly in the foot or foot and ankle, it's your big toe joint or kind of the middle of your foot or your ankle. So just as orthopedic surgeons will replace a knee or a hip or a shoulder, there are actually a few options as far as joint replacement within the foot. Looking at the big toe, a joint replacement within the big toe joint, and then also within the ankle, which is kind of some newer technology within the last 20, 25 years or so. If that's not an option, there's always conservative treatment, again, similar to what I spoke about in the other conditions. Surgical, other than the joint replacement, is a joint fusion, just kind of taking away those joints so that you don't have any pain or inflammation. So that was a really brief kind of general overview of what podiatry is. If you have any questions, we'll take questions at the end. We're always around too. So I want to thank everyone for listening to me. But I'm going to hand it over to Dr. Parikh. She's going to talk about diabetes and kind of segue into the health shop. So
Now you get to listen to me. So this will just be a really brief overview. Everyone knows what diabetes is, but it's important to know that it can manifest itself into different forms in the foot. Okay, so the elevated blood sugars can damage nerve, blood vessels, joints, and the skin. So when we have a patient that comes in, it's diabetic, we do a thorough exam. So there's different components to the exam. One of it is to assess for any vascular disease. We look at the foot, we feel the foot. Is the temperature cool? Is there any discoloration? There's two main arteries that we feel for, the dorsalis pedis, which is on the top of the foot, and then the posterior tibial, which is on the ankle side. If we can't feel for it, sometimes we have to use a Doppler to hear the sounds, and if we don't hear that, we'd have to give them different other vascular studies or refer them out. So it's very important because it predisposes patients to poor healing. Neuropathy, that loss of sensation. Patients come in, they say that they get that burning, numbness, tingling sensation. We assess for that. So what we like to do is use one of those monofilament wires. It's a flexible, thin little fishing rod, and we have the patients close their eyes and we touch different aspects on their foot. If they can't feel that, we do diagnose them with neuropathy or a loss of protective sensation. And it's very important because when patients don't have that fine sensation, they accidentally step on something, which can cause an ulceration or a break in the skin. And that in turn, even a small little scab or a callus, a breakdown of all that skin, we really have to make sure that there's no pre-ulcerative ulceration. And we assess for ulcerations, making sure that it doesn't go deep. Sometimes what we worry about is if the ulceration goes down to the bone, that can predispose them to osteomyelitis or a bone infection. So we do like to get x-rays and make sure that there's no bone erosion, or even if there's something called gas gangrene, which is a soft tissue infection. It's a surgical emergency too that could possibly lead to amputations. So some fun Friday morning statistics for you. The number of people with diabetes has risen from 108 million in 1980 to 422 million in 2014. So, fast forward 3 more years, it's estimated that 1.4 million people are diagnosed with diabetes a year. And it's not important to really know the number, but to know that it is increasing, And diabetes is a major cause of blindness, kidney failure, heart attacks, strokes, and lower limb amputations. So early recognition and prevention is key. So why do we screen the diabetic foot? Well, 15% of people with type 1 and type 2 diabetes will develop one or more foot ulcerations in their lifetime. 10% of these will go on to have a major lower limb amputation. And then of all non-traumatic lower limb amputations, 85% of people, 85% are due to diabetic foot ulcerations. That's scary. And we're not here to be like, yikes, this is scary. As long as patients are aware, I always say there's no such thing as a dumb question. If patients walk and they accidentally scraped or bruised themselves, it's really important to make sure that they check that out to assess that they have adequate blood flow, that they have good sensation, because we don't want them to not feel something and then it progresses into an ulceration, which we could have prevented. I remember seeing this when I was in school. And you always hear about prostate cancer and breast cancer, but did you know that neuropathic ulcerations have a higher 5-year mortality rate? I mean, that's pretty scary. And I know it hasn't really talked about specific diabetic neuropathic ulcerations or foot ulcerations, but we know that there's a high correlation between diabetes and neuropathy. So just something to be kind of mindful about. So some simple foot care tips that I like to tell patients, and that you can tell people that you know about who have diabetes. Check your feet every day. I know that sounds simple enough, but you really have to tell the patients to inspect their feet. Look for any scrapes, any bruising, and really check the bottom of your feet. Especially with patients with neuropathy, they don't have that sensation, so they could have stepped on something and then not realize it. And if they can't, bend over and see the bottom of their foot, use a mirror, ask a family member or a friend. Proper hygiene is very important too. I tell my patients not to wash their feet in really, really hot water, just warm, lukewarm water, and make sure that they dry, especially in between the toes, because what happens is that the in between the toe is very soft and it becomes macerated like that white kind of soft tissue, and that can be a nidus of infection. I always tell my patients too that don't go barefoot, okay? At least when you're at home, wear slippers or something to support yourself. And socks, I always tell them to wear white socks, because if they accidentally scrape themselves, they can see some of the stains or blood stains. And then checking their shoes, making sure there's no marble or a piece of wood or glass that's in there and they accidentally stepped on that too. And then just talking to their healthcare provider to be more active. Find a program that can fit their lifestyle. So for footwear tips, there's no one shoe out there that's the best. I do tell patients that you have to find a comfortable, supportive shoes. I always do the test where I take a shoe and try to bend it in half. If there's some give, some stiffness, then you know that it's giving you support. I have some patients that come in, they're like, Dr. Parikh, I got these cool Skechers memory foam shoes. I feel like I'm walking on clouds. So I always say, let me take a look at it. And I, just bend it in half. So it may be comfortable for temporary, but it's not supportive at all in the long run. So you want to have some stiffness in the arch. Flip-flops, I feel like they're cardboard, I say at least if you want to wear flip-flops, there's a brand called Bionic that has stiffer soles, so it gives you some arch support. So I really recommend that. And for ladies who like their high heels, another evil thing. I always say, if you have to wear high heels, make sure they're less than an inch. What they can do is all of that, when you raise your heel, you put more prominence into the balls of your feet. And so that in turn can cause different things such as hammer toes or bunions. Patients that do have bunions, even though if they're asymptomatic, I know some of them will wear very narrow shoes. So they're just impinging their bunion, leads to calluses that could lead to ulcerations. So they're all kind of, intertwined. I always look for the wear of the foot in the shoe and the pattern. A lot of times, if you've heard of pronation, where when you're walking, you kind of strike in the middle of your foot, so you see that middle aspect being all worn out. So sometimes it's good to, be aware of that. Get some shoes that help put your foot in a neutral position so you're not pronating, or even having orthotics. I always tell my patients you can start with over-the-counter inserts, put them in, and see if they help put your foot in a neutral position. And then again, always checking to see if there's any foreign objects inside your shoes. So how does podiatry work with the Agnesian Health Shoppe? I think we are very fortunate to have the Agnesian Health Shoppe. We use it all the time, especially for diabetic and therapeutic shoes. And I promise you, they're not old lady grandma shoes. They're actually very stylish. And compression stockings too, we use it a lot. And then I always send my patients to the health shop to get the over-the-counter orthotics. I always tell them to try that first. There are custom inserts, that they mold your exact foot type to help align your foot. But if you haven't tried it, I always say try those over-the-counter inserts. They're very effective. And then for our surgical patients, when we want to maintain, their non-weight-bearing status, it's a great way for them to get the walkers, the crutches, these cool little scooters and knee rollouts. But that's kind of like an overview, and I'll have the health shop talk more about it. And that's my cue to turn it to Brett.
Okay. Can everybody hear me? Do I need a microphone?
Yes.
Okay, how's that? Good. Okay. First of all, I want to thank Dr. Bertram and Dr. Parikh. You have been gracious to us and loyal to us, and we are thankful for that. We don't take it for granted, so thank you for that. And I also want to, before I get started, I want to introduce some amazing people. Some of you I've already talked to. I have been on what I have deemed, in a humorous way, a Medicare tour. We have been through a lot this year at the Health Shop. We went through over 50% in cuts. 58% average, enteral feeding, 88% cut. We've been through 2 rounds of Medicare cuts this year, and it's been tough. But we're okay, we're surviving it, we're doing absolutely wonderfully, and it's because of some wonderful people that worked really hard for over a year, putting together a really good plan for making it through these cuts. And so I want to introduce some of those people behind the phone. First of all is Angie Mathies. Angie is the director of Agnesian Health Shoppe. She is amazing, puts together just this cohesive team. So that is, she's our fearless leader. And Greg Newth over there, Greg is one of our assistive technology professionals. He works with our patients with custom seating. He works in patients' homes, putting in stair lifts, making sure people have the equipment that they need that fits them. Up in front here, we have Tanya Westeros. She's one of our 4 respiratory therapists who work with our patients with obstructive sleep apnea and our oxygen patients. Carla Witkowski is right here, and hopefully you'll talk to him afterwards. Carla's been with the Health Shop for years. She's in our women's health department. She works with our patients with compression stockings, with our post-mastectomy patients, with our mamas and babies with breast pumps and products. And then here in the front is Katie Gregory, this little tiny Katie who's wearing very stylish diabetic shoes, by the way. Little Mary Jane's, and they're really cute. But Katie works with our diabetic patients, and she spends a lot of time making sure that they do have the right shoe, the right liner that works for them so that they can avoid the skin breakdown and amputations that Dr. Parikh talked about. So I'm going to give you a brief overview of what the Health Shop does. So that you have just know a little bit about what we do, because we're not just about shoes. There's a lot that goes on over there. How many of you have actually been there? Good, so you've been there. So you've walked around, you've been in the shop, you toured it, that's great. So I won't spend a lot of time, I'll just give you some details you might not have known. Our sleep management program, we take care of patients who have obstructive sleep apnea. So those folks come in from our Dr. Foster, Heather Kufal, Lisa Mueller, Dr. Hadahat, and we work with pulmonologists all across, actually, multiple counties who work with us and send their patients to us. And they send their patients to us for a reason. Our compliance ratio is above the national average by quite a bit. I think it's over 89% now, Tanya. It's amazing. And so it's not about the Respironics or ResMed or the products we use, it's about the people. It's about our respiratory therapists and how much time they take to make sure that our patients are compliant. So we have 4 full-time respiratory therapists. We have technicians on call 24/7, and we're flexible. We ask that people make an appointment because it does take some time to work with these patients, but we will take walk-ins from time to time. I mean, people do sometimes need to get in, especially truck drivers on the road who maybe can't get in. So we are flexible that way. We have a resupply program. This is one area where Medicare made some major cuts in CPAP. So what I will say about that is please still send your patients to us. Because even if it's less online, it might be, but they're not going to get the work with the respiratory therapist to make sure that they're compliant. And that's important. So if they're going to be compliant with their sleep, getting the help they need for sleep apnea, we want them to have the one-on-one attention from respiratory therapy. And if we can't find a product that works for them, we give cash discounts, or we'll tell them to go online. If we really can't find something for them that works, we'll tell them to do that. But please still send your patients to us and let us help them, at least try to.
Deb, can I say something?
Sure.
So, you guys have all heard me talk about CPAP and about all of the cuts that have happened this year. Some of the things that we have tried to do is offer products that they can still get through their insurance, and then offer other products that maybe only the insurance will pay half of it. So we still have everything that we had before. If anybody tells you that we don't, that is not true. We have everything. The pricing just may be different. And here's the other thing that we do. So this year we changed the mask, again, because of the reimbursement. And we saw 1,400 patients that were already established and got them into a different mask that fit them, that their insurance would cover. And that is a completely free charge. That's not going to happen online, and that's not going to happen, if you go, apparently you go to truck stops now and you get CPAP masks. No one's going to pay you for that. So the girls that work with us at the shop are dedicated to making sure that if you need it, the equipment that you're going to get is awesome.
Thank you very much for that explanation, because that's true. Home oxygen. Some of the most major Medicare cuts were in oxygen. So when you look at oxygen, I don't know how many years ago it was $400 a month. We are probably getting less than $70 a month now. And so oxygen has been cut in such a massive amount, it's scary. To deliver oxygen probably costs about $45 to $55 a week. But we have made lemonade out of lemons. So what we've done is a couple of different things. In fact, we brought one of our portable concentrators, a couple of our portable concentrators, and the fill stations. So what we're doing is we're actually putting fill stations in people's homes so they can fill their own tanks, which is great. And we've got these new portable concentrators, and they're awesome. They give patients a lot more flexibility than they might have had before. So it's a concentrator. You unplug it from the wall, and it's a portable. And you can plug it into your phone charger while you're on the road. You can plug it into your daughter's house when you get there and charge it back up again. And so you actually have a lot more flexibility than you might have had before. So lemonade. What we actually have done, we have our respiratory therapists work with our patients to make sure that if they need a conserving device or if they need a pulse dose, we're working on that. We still provide home delivery and setup, and we still deliver 10 tanks a month. And patients can pick up as many tanks as they want whenever they want. So it's not like we're restricting them. And a lot of people don't even use tanks, or they're low tank users, so not everybody was converted. But I will say I got a call from a discharge planner in a hospital north of here, not our own. And she said, Deb, do you guys set up oxygen in homes, or you just drop it off? No, we don't just drop it off. We actually spend a lot of time, and I've been with the techs on the road, and the time they spend with patients is amazing. They will sit there with that patient and that family to make sure they understand the product they have, how to use it, when to call when they need help with it. And it's a beautiful service that we still do and we're not going away from. So just know that. We still provide the proper education on how to use those supplies. Our team has years of experience. They know what they're doing. And we are trying to strive for same-day service. So if it is an emergent situation, we are still going out there and we're still on call. Our respiratory therapists are out there for consultation if we need it, but for the most part, oxygen has not changed. We're still doing great oxygen business. In fact, with Apria closing due to competitive bid and the Medicare cuts, Apria closed their Neenah office, and Home Health United closed 4 of 9 retail locations. We're still here. And we're still serving Medicare patients, and we're still serving oxygen patients. So thank you for your loyalty in that area. Anything else on that? Tanya, anything you want to add? Okay, thanks. Women's health. We are so proud of women's health. If you haven't seen the showroom, for those of you online or listening on live stream, come and see it. It is amazing. It is beautiful. It is a private area where you could come in, especially after a post-mastectomy. If somebody's had a mastectomy and haven't had reconstruction, it's a tough thing. And so we make it as beautiful and as private and gracious as possible. This is Carla Witkowski and Denise Medell, and they are our two certified mastectomy and compression fitters. So there's beautiful private fitting rooms for mastectomy patients to come in and be fitted. We have 2 compression fitting rooms. In fact, one is bariatric. I have sat in on that, not something I really want to be watching, but they are really good at what they do and making sure people not only have the products they need, but they feel good about them when they leave. So a lot of swimwear, bras. Right now we actually have a sale on those, and actually we have people, we just did a direct mail piece on them. Women that have had a mastectomy get up to 12 bras a year and a prosthetic every 3 years. So 2 years? Every 2 years. So we actually can make sure that they get new products, so they're not stuck with it. And we've had 90-year-old women come in and didn't know that they had insurance coverage this whole time, and they've been paying for them. That's sad. So we want people to know that it is covered. We come on baby products, breast pumps and supplies, and skincare products. And I already talked about compression, and we talked about the fitting room. So Carla's been with us a lot of years. So send your patients over to us, and she'll help people understand how to use their product, how to take it off, put it on, and especially how to clean it, make sure that it's still in working condition. This is women's health, although we have some new furniture now, which we really like. So, but this is just a showroom I wanted you to see. Staying home safely. So we all know that falls are the #1 cause of injury among the elderly, and why the state of Wisconsin is putting so much time into stepping on programs and into education for the elderly on falls. So we know that. And while we have some amazing long-term care facilities here, we are blessed to have the best in the area. We still know that some people want to stay home. And so we want to keep them there safely. So some of the things that we're doing, and especially with competitive bid, we're focusing a lot on home access. We're focusing on ways to keep people home. So on your desk, I also gave you just a home access checklist. So that's that 4-page document there. Our assistive technology professionals, Greg and the team actually spent a lot of time going through that and saying, okay, what do people need to stay home safely? What do they need to think about? Because we want you to be able to stay home. So that's an assessment we give to our patients, we take out to our patients and say, what do you need to be home? So take a look at that, and we have it available all the time. So some of the things that keep people home safely are stair lifts. So if you have a hard time climbing the stairs, has anybody seen our commercial with little Althea going up the stairs? Have you seen it? Oh, good. She is an amazing lady. She was supposed to move into Bella Vista Assisted Living. I used to run Bella Vista, so I love that facility. It's beautiful. But she didn't want to go. She wanted to stay home in the home she grew up in. Her and her husband are in the home that he grew up in. And so not only do we have a stair lift in that house getting her up and down the stairs, she has a scooter on the first floor that gets her on the first floor. And she's an amputee with rheumatoid arthritis. So she's got a scooter on the first floor. The stair lift takes her to the second floor, where a scooter meets her on the second floor. She's got a ramp into her vehicle. She's got a scooter that takes her outside, and the woman is still home. So for $3,700, which is one flight of stairs, sounds steep, but that's less than 1 month in an assisted living. So that stair lift has kept her home safely for a couple of years. So she's loving it. In fact, we're looking at another one for her. So funding sources are available. We work with National Exchange Bank, so people can pay on it monthly too. So it's not like you have to come up with the whole $3,700 right up front. Wheelchair ramps, we provide ramps for access into the home or garage, and sometimes it's just a rent-a-ramp. Maybe you just need it for a month while you're getting better. Maybe you're just coming out of the nursing home and you just need it for a little while. So it's not like it has to be permanent. It can be, just a month. So we can do that. Vehicle ramps, plug-and-play vehicle ramps. And we do go to people's homes. So if you have a patient, you're really worried about the stairs, you're really worried about getting in and out of the house, call us. Greg or Craig can do an assessment if needed to just make sure they're safe and put together a plan for what they need. That's the stair lift we have on display. So if you're ever in it, you can actually play with it. I have. So mobility and home access, leading right into that. We have 2 ATPs. Greg is one of them. Greg has years and years of experience, so he does work with patients to make sure that they have the equipment that they need and measures them and makes sure that they're in their equipment that's right for their size and their height. So that's really important. We do high-end mobility devices for people with MS, ALS, muscular dystrophy. So we do have that high-end custom seating as well. And they're specializing in making sure people have what they need there. Scooters. I will say with scooters, and I want to apologize for the documentation that goes into scooters. We know it is horrible. We get that it's daunting, and we know why. If anybody might remember years ago, everybody and their brother got a scooter. Everybody was riding around in them. And so Medicare did get wise to that. Sometimes there weren't real people behind the scooters, and there wasn't real need behind the scooters. And so that is really why. It's because of that. I don't know if it was always fraudulent, but it definitely was a problem. And so that is why the documentation for power mobility is so awful. It's because they want to prove there's real people behind it. So we apologize for that, but unfortunately we're stuck with it. This is just a little sample of what's going on in our mobility department. That's Craig Koulis, who's our other ATP. So you can see that. And now we get to the shoes, which leads into what Dr. Bertram and Dr. Parikh had talked about. I think Katie was going to pass some of those around. So we talked about, they're really cute. For women, there's some really adorable shoes and tennis shoes. So it's not like your patients are going to be wearing a shoe that looks, I hate to say this, but like an old lady shoe. They're not. They're really nice looking shoes. So we have a full line of Dr. Comfort diabetic shoes. We also have the inserts and the socks. So we have diabetic socks, which are seamless. They are really nice and comfortable. The inserts inside the shoes are removable. So when you get the shoe, you won't have that insert in it. So Katie, what she does is she spends time with patients. She does a heat impression of their foot. And so that we can match the liner to their foot. The shoe has a higher toe box so that there isn't going to be that rubbing. So they're really nice shoes. The one thing Medicare does cover one pair of shoes a year and 3 liners a year. And most insurances too. So if your patients do have type 1 or type 2 diabetes with any kind of pre-ulcerative foot callus, Medicare does cover the shoe. So, make the referral. We'll work with the patient's primary diabetic doctor to make sure that we get the documentation we need. They do have to be compliant with their diabetes program. They have to see their their doctor at least every 6 months, correct, Katie? So they have to be compliant with their diabetes program. And that's the one caveat. So, and Katie will be here if you have any questions afterwards too. So,
We
yes.
know that Medicare covers diabetic shoes, but does commercial insurance or Medicaid cover?
Yes, it does. So Medicaid, insurances.
Fiscal insurance does.
Fiscal insurance, Katie, covers shoes? Yes.
You need a doctor's order?
Always. We do need a doctor's order, and they do need to be compliant with their diabetic program. They also have to have some sort of pre-ulcerative foot callus. That's to have it covered. Unfortunately, there has to be that there. Any other questions on that? Because I'm happy to. Okay, lots of time. So if there's any physical therapists in the room, I'd like you to close your ears. So I apologize for this. Lift chairs. I know physical therapists do not like lift chairs, but sometimes they're necessary. People do have a hard time getting in and out of living room furniture. And we have a full showroom of lift chairs. So lots of fabrics, lots of colors, and they do keep people independent at home. So we do take them out, we set them up, and make sure sometimes, and I'm hearing from our patients and families that we have moved furniture as well. So, and they even moved our furniture, they said. So we do have HydroLift products for any surface. If people do have a hard time getting out of chairs, it's just a small mechanism you sit in that can give you a little boost. But we also do cash discounts on those chairs. So if people want a chair and they don't want to bill insurance or go through that whole documentation process for Medicare, our cash and carry rate is pretty reasonable, very reasonable. In fact, you could probably go into any store to look at a recliner, and we're pretty close to what you pay for a regular recliner. And then our retail durable medical equipment shop. So for those of you that are non-clinical, DME is durable medical equipment. So we have a full showroom, and our DME specialists are trained in insurance. They're trained to get prior auths. They know what they're doing. So I will say for this, we do have walkers that are cash and carry. And I want to point out that And we bill insurances too, and Medicare. But you can get a walker at Walmart. I mean, we'll admit it, you can get a walker at Walmart. But you know what? We've seen people walk in with the Walmart walker and it's like 3 feet in front of them and it's the wrong height. So we spend time making sure that people know how to use it, that they are fitted for it properly, and that it's right for them. So, and we also fix it. So it's important for you to understand that while we might not be the cheapest, we've really done a lot of reducing prices on walkers, coming down to what everyone else is selling them for. But we also bill insurance for them too. So we have an expanded cash and carry line, exercise equipment that the zone has recommended, from yoga balls and TheraBands, pain management products. Dr. Henslin has given us a whole line of supplements that he wants us to sell for his patients, podiatry, orthotics and bracing, your bath aids, your reachers, grabbers, shower chairs, commodes. We have all of that as well. So what I will say, if you're thinking about products that your patients might need, and you're thinking it would be nice if we sold that, call me, because we'll look into it. We'll call our vendors, we'll find out what the prices are, and if we need to sell something in the shop that your patients need, and you want to refer it, call us, and we'll definitely add it to the shop if we can. And that's a picture of our showroom. This reception desk, I will say, is the reason why, even though it's beautiful, is the reason why our phone system's so frustrating. So many of you in the 40-some presentations I have done, your phone is a problem. We know it. We know that our phone's an issue. We're working on it. And in front of you, you have a phone guide. So while we're working on the phone system, it's beautiful front desk, but it only brings to that desk. And when people are standing there trying to check out their checkout, that's why, because somebody's with a patient. So while we work on that, in our old building, the phone would roto over to the next available person all the time. In our new building, it doesn't. And by the sheer volume of busyness, which is a good thing, it's impacted our phone system. So that phone guide is in front of you to use. So if you need to talk to compression, call compression. If you need to talk to someone in mobility, call mobility. If you want to talk to someone who just deals with oxygen, call oxygen, okay? And then this is our wound care nurse, Nikki. So we do provide wound care supplies. So she's an RN that works specifically with wound care. And we're located right next to the wound care clinic, which is perfect. And she's working on making sure that we have the right reimbursement, that we get insurance coverage. And sometimes we'll get orders for things that the insurance won't cover. And so then Nikki's working really hard to find a product that will be covered. And so she's working with our nursing homes and our home care department and patients and families that might need products delivered or actually mailed to their home. We do have a resupply program as well for ostomy, wound care, urological, feeding, and incontinence supplies. So we are making sure that patients have what they need. We're making monthly and quarterly calls. We never send anything without approval, without permission. And so we make sure that if they really need it, it's there, but if they don't need it, we don't want, the last thing you want to see is a closet full of supplies nobody's using. So we are making sure that they truly need that supply. And I mentioned earlier, we fix things. So you might have bought it at Aldi's, and that's just great. But we're going to fix our product and make sure it's in working order and make sure the patient has exactly what they need at the right product for the right disability, and that we're there to fix it if it's broken. So that is that. One other thing I will say about and I think most of you know how to find our Medicare criteria online. Do you all know how to find it on Vital Signs? No? Can you bring up Vital Signs?
Sure.
I just want to show you how to get to our criteria. While Colleen's bringing that up, Medicare criteria for, and bring up the departments of the health shop. And then click on that bottom link. It says local coverage determinations in the very middle bottom.
Here?
There. Click on that. And we're working, there it is. The website's been working on it, it's a little slow. So here's our Medicare criteria where all of our orders and all of our documentation is. So we know Cerner has about 200 or so durable medical equipment orders that are absolutely useless to you. They don't work, they don't come through to us, they're not even correct. They don't even have the right Medicare criteria attached to them. So this is where our Medicare criteria is located. So if you would click on, go down to Walker. Can you scroll down to Walker? There you go, Walker.
This one, right?
Yep, that one was good. So this tells you what the Medicare criteria is for a walker. When I first started for the Health Shop, I was frustrated like you. I was in long-term care and I wanted my durable medical equipment and I wanted it now. I once put a patient on hospice because I knew he would never get that chair before he died. He died 12 days later. Thankfully, it was the right thing to do. But it's tough, and this industry is tough, and the documentation is tough. And we understand that. But we are hearing you, and we're trying to make it easier. When I first started, I went on to Medicare, to CMS's website, the Centers of Medicaid and Medicare Services for those non-clinicians. And I thought, it can't be this hard. It really can't be this hard. And so I looked at it myself, and we took like 50-some pages for power of mobility and put it into 2. So it really is, the documentation we're asking for is really what Medicare is asking for. And we can't not get paid for claims. We're not a national company. So we are really trying hard to be wise stewards of Medicare's money. We're trying to make sure that we have everything correct, and sometimes that is frustrating. But know that we're hearing you. And we're working with IS to get this in Cerner. So we're about a month and a half away from getting the orders in Cerner. So scrubbing out the 200 or so that are useless and putting in the 20 or so that are good. And then we're also working with IS to be able to put our Medicare criteria into somewhat of a template form. So for power mobility, please explain the mobility limitation that prevents you from using a walker or a wheelchair. So we're trying to do that. Angie and her, has been working on this for 5 years? 5 years. And so while we know it's frustrating, we hear you, and please know that we're working on it. And we thank you for your patience with us. We know it's a documentation issue, is a Medicare issue, not an us issue, and we know that you know that, but we just thank you for your patience in advance. And we thank you for your loyalty. We know there's a lot of other agencies out there that do what we do, but we all know that we're part of the same family. We're on the same team. So we just ask you to be patient with us. Call us if there's a problem. Work with us, and we'll definitely try to do everything we can to manage you up and make sure your patients have everything that they need. Any questions?
I have a
Yes.
question for the pod over there.
Good.
Those crazy shoes that go over your toes. If you know what I'm talking about, I have no idea what they're called.
Like the Vibram, like the 5.
Yeah.
The
Yeah,
toes.
it's like wearing, it's like being barefoot. Are those, I guess, what is your take on those shoes? I see those out, I see people running in them, and they're like, I ran 10 miles in these crazy shoes or whatever, and I see commercials for people running through the woods on them, and I can imagine that. In your talk, you would go with shoes that you would probably recommend to people.
I don't recommend them.
Do they serve any purpose? Is there a benefit to them at all?
The minimalistic, design is it depends who you listen to. I guess it depends who you read. From a pure support or biomechanical standpoint for your foot, there is no support really. And people who use them, you're right, there are a lot of people who love them and swear by them. I've also seen a lot of people who have tried to get into them, after running years and years in normal running shoes or tennis shoes. And then they lose that support, and all of a sudden they end up with a stress fracture or something like that. I mean, it's different, obviously, and at least in my experience, I've seen more, cons than pros to using them. So it's definitely patient dependent, but in general, I would never recommend them. No.
Thank you.
I have a question for you also. At what age would you suggest a type 1 diabetic see a foot doctor regularly? I have a teenage son who's a type 1 diabetic. He hasn't seen a foot doctor, but seeing everything that I've seen, gets me a little anxious.
There's no set age. I think if you're borderline, you're pre-diabetic, you're recently diagnosed, or you've been diagnosed for 10, 20 years, there's no set age. So I think, you should probably, if he hasn't seen a podiatrist before, had any thorough foot exam, I think now would be the best time.
Okay.
Yeah, I think it's good for type 1 or type 2, young, old. Any diabetic should probably see a podiatrist, just to have a baseline evaluation. And then based off of that, kind of dictates how often we'll recommend, that patient returning. I mean, if someone's high risk, has neuropathy or has a history of an ulceration or an amputation, I mean, really it's almost once every 3 months, if not more often. Someone who's a diabetic, well controlled, no signs of neuropathy or blood flow issues, sometimes we can stretch that out in once every 6 months or once every year even. So I think it's definitely important to have that baseline evaluation either by your primary doctor or by a podiatrist. And then from there it kind of dictates how often we'd like to see you again.
Thank you.
What are your thoughts on gel insulin?
Like the Dr. Scholl's jelly.
Well, there's different types, yeah.
You probably have a different view, but I always tell patients to try them. I know they might not be the most supportive and they're not based on your exact foot type, but I do find that if patients at least have some type of support, whether it's gel, whether it's stiff or soft, that sometimes that can really help cushion and align the foot.
So we are married, we don't fight a whole lot, but I tend to disagree when it comes to those. I do hear where she's coming from. I mean, it does provide that cushioning or that good feeling, but at the end of the day, to me, it's just a Band-Aid. The reason you're having pain, there's a biomechanical issue going on. There's a lack of support or something underlying all of that needs to be addressed. And you can't address that with just sliding in a gel insert. It's going to feel good for a while, but again, it's a Band-Aid. You still have that, whatever that issue is, that needs to be addressed in some form or another. So.
I'm just thinking if you don't have an issue or pain, but you use the gel insulin, because I use them and I like it because when you put the pressure, the gel goes away from there and supports the arch and other parts of the foot. So it's not for me, it's not getting the pain, it's just they feel good.
We had one question on the text line about bare feet. They said it feels better to walk barefoot. I know I've heard you talk on that before. Thoughts on?
I mean, I think it's patient dependent. Some people, I have had actually a good number of people come in who say, I just feel better walking barefoot. And that's fine. I think we definitely don't recommend barefoot walking to diabetics, as she talked about. It depends on what's going on. I mean, around the house, sure, but I mean, obviously outside or out in public, no. But
And is it comfortable because if they wear a shoe that they feel that it's too tight? Like, are their shoes not comfortable? So that way, if they're barefoot, maybe that's why it's comfortable. And maybe that would be a reason to see if they're wearing properly fitted shoes. If their feet sweat, maybe wear socks that have that width control to control some of that moisture.
Thank you.
Thank you. All right, the green slips are in. Okay, who wants to pick the winner? One of you pick our winner?
sure.
Okay.
Carla with
That's one of us will win it. Put it back in. Pick somebody else.
You don't want it?
No.
Oh,
No?
all right.
They get a huge
All right.
discount.
Okay, now pick me.
I get a
real
pretty
now.
good deal.
Henry Ratton?
Henry Wraith. He's in Waupun with us, so he's a volunteer, so he won. Well, thank you very much for being here today. Have a great weekend. Okay, do you get that to Henry? Yes, I'll get it to Henry. Nice job, Deb. Thank you very much, doctors.
Great.
Nice meeting you. Thanks for having us. Thanks, Deb. Good job. Yeah, it wasn't that big. I mean, it's so infrequent, but